Καλησπέρα από Ηράκλειο. Είναι μεγάλη μου χαρά σήμερα να παρουσιάζω τη Μαρία την Basta, που θα μιλήσει για ευρήματα ύπνου, αντικειμενικού ύπνου, as a potential biomarker of cognitive function in the elderly. To speak in English, correct, Costa? Yes?
Ναι, στα αγγλικά. Everything's English.
Okay. I know Maria Basta for almost 20 years. I met her even as a resident at the Department of Psychiatry in Crete, and then she spent time with us at Penn State at the Sleep Research and Treatment Center. Maria is now an associate professor of psychiatry, and also she is the chair of the Department of Psychiatry at the University of Crete. Furthermore, she is now the director of the Alzheimer's Day Center that is just established within the Heraklion University Hospital. Maria has spent a lot of time on researching sleep. She was also one of the important contributors in a large grant we got back then with including neurology, Yannis, and Plaitakis, and internal medicine, Dimitris Boubas, and community medicine, primary care medicine with Professor Leonis. And as we will explain, there were two phases of that. So we present data from the second phase. Also, Maria now is the PI, the principal investigator of a follow-up grant on this cohort. And she's studying the long-term and associations between sleep, inflammatory biomarkers, and stress in patients with MCI, as well as with normal cognitive function. And this project has just started due to the severe delay due to the pandemic. Without any delay, Maria, your turn.
Okay, thank you very much. Good afternoon to everybody. I would like to thank my mentor, professor and friend, Alexandros Vgontzas, for the introduction and for all his support and help during all these years. We've had a very long way together, which is going on, hopefully for another 20 years, as I've told him. So today I'm going to talk, as Dr. Vgontzas just said, about objective long sleep duration in elderly. And I'm going to try to convince you that it is a potential biomarker of cognitive function in elderly with cognitive impairment. So this is the outline of my talk. I'm going to make a short introduction and describe the Cretan aging cohort, where our data come from, and it's going to be three parts. I'm going to talk about sleep in elderly with cognitive impairment and long sleep duration as biomarker of cognitive impairment in this group. I'm going to go on talking about sleep duration and genetics in patients with cognitive disorders. And then I'm going to talk about objective daytime sleepiness, inflammation, and cognitive performance in patients with dementia. And finally, we'll close off with clinical implications and our conclusions. So to start, let's say that aging of the population is a characteristic of modern Western societies. And it is known that in these societies, about 20% of the general population is over 60 years old. Based on a recent study, Greece is found to be the sixth highest in terms of percent country among about 2,000 countries worldwide with people aged over 60 years old. So we are getting older. However, aging of the population is, as we all know, associated with increased cognitive impairment disorders prevalence, which in turn is associated with high morbidity and mortality. And dementia is known to have the highest combined burden expressed in years lived with disability, as well as cost among all chronic diseases in Greece, as well as in other European countries. So since there is no cure for dementia, research lately has focused a lot on potential modifiable factors for dementia, such as obesity, sleep, physical activity, diet, social contacts, medical and mental disorders. And there is a lot of research on the possible mechanisms that are associated with it, such as stress and inflammation. So I'm going to present you the work of the Cretan aging cohort. And this is the research group that Dr. Vgontzas already talked about it. This study was conducted in the University of Crete in the School of Medicine. And as you can see, it was a collaboration of 4 departments. Department of Psychiatry with Dr. Vgontzas, who was the PI of the study. Department of Neurology with Professor Klaitakis and Yannis Aganas. Department of Medicine with Professor Boubas and Dr. Panagiotakis, and the Departments of Social and Family Medicine with Professor Leonis and his general practitioners network that contributed to the study. And this is a figure of our study. And as you can see, we had a reference population that came basically from, mainly actually from the rural area of Heraklion. The population, the reference population was about 40,000 people. Among those, 13,000 were over 60 years old. 8,000 would visit the primary health care centers of this study within the year that we were recruiting people. And about 4,000 of them were contacted by the 18 physicians, the general practitioners that were participated to the study. So the study had 2 phases, as you can see. In the first phase, we saw about 3,300 people that came to the general practitioners, to the specific centers, for any reason. It could be for a cold or just to have their medications prescribed or whatever, or to have their blood pressure measured. And they all filled a structured questionnaire, including information that had to do with sociodemographics, lifestyle, clinical, medications, etc. They were also, all of them, assessed, their cognitive function was assessed by using the mini-mental state examination. So among those, they were divided into 2 groups, as you can see, those with a normal mini-mental state examination within the normal range, and those with a mini-mental that could be indicating of some cognitive impairment. After that, in the second phase, we examined, we invited all these people and a subsample, a random subsample of those here, the normal ones. And they were all examined very thoroughly by a group of experts that consisted of a neurologist, psychiatrist, and geriatric medicine, and a very thorough neuropsychiatric evaluation was conducted. Additionally, all participants of this phase, the second phase, were thoroughly examined with neuropsychological examinations that took about 2 hours to finish. So it was we did a lot of scales, and it was coordinated by Dr. Simons, who is the professor of neuropsychology in our department. Additionally, during this phase, we conducted sleep studies using actigraphy, which is an objective way of measuring sleep. And a blood draw was drawn, and we measured inflammation and stress hormones, plus genetic studies were conducted. So that was Thalys. And here, as you can see, is the study that we have recently started, stopped for a while due to COVID, but now we are collecting data again, which is actually a follow-up study, basically of those who were back then diagnosed with MCI, and we see them, we reevaluate them 7 years later to determine their cognitive status and try longitudinally to see the possible risk factors that may be associated with deterioration of their cognition. And well, I used this slide because this presentation was also presented in the United States. So to show where Greece is in Crete. And as you can see here, this is the area of Heraklion, where our participants came from, basically from the rural area, plus about 15 to 20% that came from the city of Heraklion. And just to have an idea of our population, in the first phase, about 4% had formal diagnosis of dementia. So that was among the over 3,000 people that we saw. And when we examined them in the second phase, and we included over 500 people, dementia was actually diagnosed in about 11%, while about 32% had a diagnosis of mild cognitive impairment. So prevalence of cognitive problems were rather high in this population, and this is published by Yannis Zaganas in 2018. Now, let's see about the first part, talking about associations between sleep duration and cognitive impairment in patients with mild cognitive impairment. So I'm going to show you some data that were presented in an article that was published 2 years ago, actually, in the Journal of Sleep Research, which is the official journal of the European Research and Sleep Society. And we also got an award for this paper as one of the top downloaded papers of the year. So the prevalence of MCI increases among elderly and is associated with high risk of dementia. So identifying factors that may contribute to the progress of MCI to dementia is critical. On the other hand, sleep disorders in elderly are very common, and based in big epidemiological studies, they seem to have a prevalence of about 50% among elderly aged 65 and longer, who have a report and chronic sleep complaint. Furthermore, there seems to be an inverse association between disturbed sleep and especially insomnia symptoms and cognitive performance based in both our study and other groups. So longitudinal studies examining the association between subjective sleep duration of habitual sleep at baseline and cognitive performance also have shown that at follow-up, they seem to have mixed results. Some studies report that short sleep duration is associated with cognition, long sleep duration, whereas other studies find no association with cognition. And this is again subjective, meaning self-report sleep duration. Very few studies, however, have examined associations between objective sleep and cognitive performance, and especially within patients with MCI. There is a very few, 3 studies, as you can see, using polysomnography, PSG, which means that the people that were examined had to go to the sleep lab, they had a lot of electrodes on their head and so on. And these studies have very small samples. And their findings in terms of sleep in this group of patients are rather inconsistent and non-specific. There is a few studies using actigraphy, which is another method of assessing sleep objectively using a watch that the participant has to wear all the time during the 24 hours. And as I'm going to show you in a little while, this method practically assesses the movement, and there is a threshold. So above the threshold, it calculates that actually the person is awake, a wakefulness, and if movements are very low, then it measures sleep. So based on the movement. So these studies have shown a positive association of total sleep time with cognitive scales in total sample, including MCI patients, not only in MCI, whereas 2 other very small studies have found no association of sleep duration and cognitive performance. So our aim was first to compare non-cognitively impaired elders with MCI and dementia patients, and to assess the association of objective sleep with cognitive performance in a group of MCI patients that we examined during the second phase of the Cretan aging cohort. So in this analysis, as I already said, we included people who went to the primary care physician in the group of primary care participants that participate in the Cretan aging cohort for any reason. They were all over 60. They had a mini mental state examination score at baseline. They had a diagnosis based on neuropsychiatric and neuropsychological evaluation of their cognitive state during the second phase. They also had 24 hours consecutive of actigraphy. And of course, they wanted to participate to the second phase. And this is the actigraph that participants wear. And this is what we find. So there's periods of movement, a wakefulness, and periods of very low movement, which are measured as sleep. In this analysis, as you can see here, we included 100 cognitively non-impaired people, 121 with MCI, and 50 patients with Alzheimer's disease. So in this table, you can see the objective sleep characteristics by diagnostic group. And what we found is that basically the group of Alzheimer's disease patients sleep longer, and they sleep longer objectively during the night and during 24 hours, which means this is a sum of nighttime and daytime sleep. And they stay longer in bed. This is time in bed, as you can see, and this is about half an hour, as you can see, or even an hour longer compared to the other 2 groups. Now, when we try to see any differences between the non-impaired and the MCI, as you can see, there were no differences between them. So sleep duration was very similar, while there were no differences in terms of the quality of sleep. That cannot, does not really, we cannot really evaluate it that well, since we don't have EEG that we use in PSG, in polysomnographic studies. Then we examine the sleep characteristics by MCI subtype and to see if there were any difference. And as you can see in this table, there were no statistically significant differences between the subtypes of MCIs and within those, and between them and the non-impaired. However, what we did find when we checked it is that we saw the associations between long sleep duration and neuropsych test scores. And we did find that in the multi-domain MCI group, there were several associations between specific tests of the neuropsych testing and long sleep, meaning that the longer they slept, the worse they did in the test. So we concluded that elderly patients with MCI have similar objective sleep duration with normal controls, while Alzheimer's disease patients sleep longer. Long sleep duration in patients with multi-domain subtypes of MCI is associated with critical non-memory cognitive domains. And based on all this, we concluded that long sleep duration may be an early biologic marker of accelerated cognitive decline. Now, let's see if long sleep duration can be associated with the genetics. ApoE allele variant is associated with increased risk of Alzheimer's disease and related dementia. And it is known that ApoE4 is linked 2 to 3-fold increased risk for Alzheimer in heterozygotes and 10 times in homozygotes. We have previously, as I already said, we have shown previously that among cognitively non-impaired elderly and patients with cognitive impairment, meaning mild cognitive impairment, Alzheimer's disease, objective sleep duration is associated with worse cognitive performance. Also, previous studies have shown association between subjective sleep quality and subjective sleep duration and ApoE4 gene. Only 2 pilots in small studies, pilot studies examining objective sleep and ApoE allele have been conducted, and their findings were conflicting. So one small study showed that among healthy elderly, ApoE carriers had shorter sleep duration and more disturbed sleep with more awakenings and more wake time after sleep onset compared to non-carriers, while another pilot study among MCI patients found no difference both in sleep duration and sleep fragmentation between carriers and non-carriers. So we tried to examine the same question in our population, and this was published last year in HIAAD. And the aim was to assess the association between ApoE4 and objective sleep duration among patients with mild cognitive impairment and Alzheimer's disease. So again, here we included people from the cretin aging cohort from the second phase practically, with a diagnosis of MCI and Alzheimer's disease, who also had actigraphy 3 days for 24 hours, and their ApoE4 allele was measured by our colleagues and Yannis Zagana especially. So we included about 90 patients, and as you can see, almost half of them had Alzheimer's and 40 of them had MCI. And here is the demographic and clinical information by ApoE group. And as you can see, no statistical differences were found between carriers, 18 people, and non-carriers, of the allele in terms of diagnosis, demographics, and depression and psychotropic medication use. When, however, we checked about objective sleep variables, we did find that those who carried the allele slept longer compared to those without it. This is hours of sleep, and as you can see, they had about half an hour longer sleep during the night, and also about the same difference during the 24 hours, meaning that both nighttime sleep was longer and daytime sleep. And the differences was marginally, that was significant. Sorry, that was significant. Interestingly, there were no differences in terms of subjective sleep, so what they reported between the two groups. So we concluded that among patients with MCI and Alzheimer's disease, ApoE4 carriers have longer objective nighttime and 24 hours sleep duration compared to non-carriers. So objective sleep duration seems to be a genetically driven preclinical marker associated with worse prognosis in elderly with cognitive impairment. So finally, I'm going to talk about daytime sleepiness, inflammation, and cognitive performance in patients with dementia. So inflammatory markers are known to be elevated in patients with cognitive impairment and are also associated with excessive daytime sleepiness. In addition, as already said, we have previously shown that patients with dementia seem to sleep longer. This is another publication of last year, again in the Journal of Alzheimer's Disease, in which we tried to test the hypothesis whether pro-inflammatory cytokines, IL-6 and TNF-alpha, are associated with objective sleepiness and worse cognitive performance, focusing on memory in patients with dementia. So again here, we included patients from the second phase of Thales study, who had the diagnosis of dementia, and of course had actigraphy and a single morning plasma IL-6 and TNF-alpha measurement. And here you can see we included 46 patients with dementia and 85 non-impaired, cognitively non-impaired participants. And here you can see the general demographics and their depression rates and medication and so on. So what you can see is that the demented group, as expected, were older, and they had fewer years of education. Of course, they were more impaired. Of course, they had a lower mini-mental, and the Loyton scale was higher. They were more likely to be depressed, and they use more. They had significantly higher psychotropic medication use and benzo. So what happens in terms of sleep? As you can see, and we have already shown that before, people with dementia slept longer, about half an hour, so you can see longer. And they also napped longer, and this is the daytime nap, as you can see, which was about, it was not statistically significant, however, it is clinically significant, because as you can see, they slept for about 15 minutes longer compared to controls. And the 24 hours sleep, so nighttime and nap, was significantly higher in the demented group. Then we examined the differences between cognitive performance and EDS measured with napping or not napping in the group of the demented participants. And we divided them into those who napped and those who did not nap. And as you can see here, nappers did worse in several scales, in several tests that are associated with memory in the neuropsych testing. Then we tried to examine the correlations between sleep and sleepiness and IL-6 in patients with dementia. This is the demented group. And we did find that those who slept more, were sleepier, had higher levels of IL-6, higher inflammation levels. So those who slept more easily during the night, napped longer, or had 24 hours higher total sleep time, as I said, had higher levels of inflammation within the dementia group. Okay. So based on the above, we concluded that objective excessive daytime sleepiness measured with the napping is increased in patients with mild to moderate dementia compared to cognitively intact controls. Within patients with dementia, excessive daytime sleepiness is associated with worse cognitive performance. And IL-6 levels are associated with objective excessive daytime sleepiness in patients with dementia. So based on all what I have presented to you up to now, we come to the conclusion that long sleep, objective long sleep, not subjective.
Maria, sorry, I think your slides are not advancing. We're still just seeing the correlation slide.
Okay. Sorry, but I don't know. Okay. Can you see them moving now?
No, it seems to be, at least what I'm seeing is one slide, correlations between sleep and IL-6.
Correct, I agree with Kostas. That's okay.
Okay, somehow okay. For some reason they post, can you see it now?
No, it doesn't.
Maybe you need to stop share and...
Okay, I'll do that. Okay. Can you see it now? Is it okay?
Yes, we can see it. So maybe you move to the slide and then...
Yeah. I'll go there. Oops, that was too fast. Okay, let me find it. So, sorry about that.
Maybe you need to close the camera because the internet is slow.
Sleep seems to be a biomarker of some cognitive issues, and there is several to explain it. So
Maria,
one way to see it is that sleep, there seems to be a bidirectional association between sleep and beta amyloid, which is a pathological hallmark of Alzheimer's disease, which means that sleep and wakefulness cycle. But on the other hand, deranged sleep leads to higher deposition of the amyloid. Another explanation may be that abnormal tau may be the earliest associated observed pathology related to sleep regulating regions of the brain. Another explanation may be that elevation of inflammatory markers, the elevation of inflammatory markers in cognitive disorders. Another thought suggested by previous literature that is associated specifically with ApoE4 carriers is that those that carry the allele may have higher rates of sleep apnea, while some other research says that long sleep in these people may be associated with deregulation of the melatonin hormone, which is a sleep regulating hormone. Now, what are the clinical implications of our studies? As already said, there is no cure for dementia up to now. So efforts are focused to prevention. So it is really important to identify people at risk. And in those people, we can try to make some intervention. Our study that objectively are biomarkers of disease severity in patients objectively high total sleep time. Interventions may be made, such as multitask, so training, blood pressure, regulation, and obesity, and
Δεν σε ακούμε, Μαρία. Ναι. Μαρία, μας ακούει?
Alexandros, she just came back.
Oh, okay.
Να κλείσει την κάμερα ίσως εκεί. Αυτό μάλλον είναι.
Maria, έχεις mute. You're muted, Maria. Maria, you're muted. We cannot hear you.
okay. So as I said, all this multitask intervention in this group at risk may be helpful to slow down the deterioration of cognitive impairment, while maybe future research could explore treatments targeting inflammatory pathways, since we saw that inflammation levels seem to be elevated and associated with cognitive impairment in this group of patients. Plus, another thing is that the administration of sedative antipsychotics in this group of patients that are given by practitioners should be given with very, very much big caution. So I heard the other day Dr. Vgontzas talking about antipsychotics, the second generation that can cause sedation and sleepiness. These may not be helpful at all in this group of patients. So in conclusion, summarizing what I have told you, we think that elderly patients with MCI have similar objective sleep duration with normal controls, while Alzheimer's disease patients sleep longer. Within multi-domain subtypes of MCI, long sleep duration may be an early biologic marker of accelerated cognitive decline. ApoE allele is associated with objective long sleep duration in elderly with cognitive impairment, and in demented patients with objective daytime sleepiness may be a biologic marker of the severity of dementia. Future directions, longitudinal studies are needed, and these will help to see risk factors at baseline, how they develop, how patients develop, and use of PSG, which is the gold standard for sleep studies. This is polysomnography, is going to be needed so that we can assess objectively the sleep quality and the sleep apnea in those people examined. And this is what we are going to do, and we're doing actually in the current research study that you can see here. It's titled Sleep Apnea and Poor Sleep as Risk Factors for Decreased Cognitive Performance in Patients with MCI, the Cretan Aging Cohort. And hopefully COVID will let us come with some interesting and helpful for those people results soon. So thank you all for your attention. I'm sorry about the technical difficulties. I want to thank Dr. Vgontzas once again, and the podium is open to questions.
Thank you, Maria, for a nice cohesive presentation of the studies. I think the floor, as you said, is open to questions, discussion, comments, whoever wants to say something.
Suggestions?
Well,
Sure.
I have a few. I can kick it off. But first, can you remove the share slide? And I'd like to ask everyone to go on video because I'd like to get a photograph of this group. Just a matter of showing what we do as a Hellenic initiative. So Maria, I have a couple of questions. One question is the mechanistic one. There's a fair bit of evidence, and you referenced Adam Spira's work from Hopkins in regards to MCI. There's a fair bit of later work from that also suggesting that there's something very specific about slow wave sleep that has a lot to do with why sleep disorder is a predictor of cognitive decline. And the hypothesis is that slow wave sleep is a phase of sleep where toxins are cleared from the brain through the lymphatic system. And therefore, if there's less slow wave sleep, the lymphatic system doesn't work well and amyloid accumulates, yada, yada, yada. So I was just wondering if you would comment on that as an idea, because it focuses a future intervention option on pharmacologic approaches to improve slow wave sleep. And perhaps one of the most effective improvers of slow wave sleep that I'm sure Alexandros knows about is trazodone. So maybe you could speak a little bit more about this issue. You put it in the context of inflammation and all these other things, but it might be that there's a core function of sleep that is lost that could be rectified with a widely available pharmacologic agent.
Thank you for the excellent point. You're absolutely right. I didn't talk about it because actigraphy cannot assess slow wave sleep. As I explained to you, we need EEG recordings so to see what slow wave sleep is like in our population. So I don't have this data. That's why I didn't talk about it. But you're absolutely right that slow wave sleep may be a way to explain deterioration. And recently, there has been a study, and maybe Dr. wants to talk more about it, by a group in California, if I recall correct, that they did find the administration of trazodone that does increase slow wave sleep, and it is the number one medication given for insomnia off-label in the United States and maybe worldwide. We use it here too. Improves cognition, and it may be a very helpful way to treat these people, and by improving their sleep, as you say. So I totally agree with that. And maybe Dr. Vgontzas would like to add some more.
If I can say something, Kostas, yes, the idea, about slow wave sleep and the reduction of slow wave sleep and having to do with cognition and so forth has been there for years, even for insomnia. In fact, some years ago, there was an effort to discover specific drugs that enhance slow wave sleep, but unfortunately, they did not make it to the market for various reasons. As far as trazodone, yes, truly, I believe, and you might have seen the last couple of studies we published in the Journal of Clinical Sleep Medicine and the other one in the Journal of Sleep Research. We compare trazodone not to patients with mild cognitive impairment, but to within insomniacs, and we found that trazodone is superior to cognitive behavioral therapy in terms of increasing the length of sleep, as well as reducing cortisol, and also decreasing doing an EEG power analysis, decreasing the fast frequency and increasing this long frequency power. I have to say, in my practice, in patients with insomnia, including elderly insomniacs, and particularly those, with a sleep complaint, of course, and mild cognitive impairment, mostly those with dementia, my preferred drug for the time being is trazodone and not the other benzodiazepines or benzodiazepine-like receptors, such as, zolpidem, Ambien in the United States. I think it's, Maria, remind me the name of Ambien. Stilnox. I do not recommend it, and I have seen very good responses in many patients.
It is a pity, however, that trazodone, in its form that we use it for sleep, not the CER form, is withdrawn in Greece, and we can't find it anymore, unfortunately.
Yeah, Maria is right. I was very much unhappy when the company here, and well, as you know, of course, in the United States, you can find trazodone in a simple form, the immediate release 50 milligrams, 100. In Greece, when the extended release came up, which is 150 primarily for depression, the company withdrew from the market the other trazodone.
And much more expensive.
Because one is more expensive, the other is very cheap, Like you can get a supply of trazodone of 50 milligrams for $1 in the United States or for €1. So that's unfortunate. And, I had a problem with some of my patients to which medication to switch them. So you see here how medicine and economics interact not always in the best possible way for the patient.
And may I add something? Based on this idea, on your comment, we had thought about it and we went back to check if those on trazodone in the big database of the 3,000 plus, because we had the medications, we wanted to check if they had better scores in MMSE. However, the number was very, very low. It was not many participants used the medication, so we could not really check it, unfortunately.
This is because, Costa and the other colleagues, in Greece, still, many physicians, including primary care physicians, psychiatrists, use a lot of benzos, like, things like Xanax, alprazolam, and zolpidem, and so forth. They are very, very widely prescribed. While, as in the United States, trazodone is the second most prescribed medication for insomnia. And in fact, a recent study in JAMA by some people from Harvard and Pittsburgh, University of Pittsburgh, that worked together, they showed that despite it's not FDA approved, it's not FDA approved for sleep, it's not recommended by the American Academy of Sleep Medicine, the trends is they see the statistical data indicate an increasing trend in the last decade. So it's the second most prescribed medication in the last 20 years without having a pharmaceutical company promoting its use. So this means, that these primary care physicians, they find something useful in that, or as we're talking with a group of sleep people in the United States, or they are all crazy. The latter is not likely, so I think it's a medication that we have to explore.
Shall we see if others have questions, comments?
Can I ask? I have a question and a comment. Okay. The question is, did you find any difference between patients with other treatment with donepezil or any other kind of anti-dementia drug and patients with and without in the sleep disturbances?
Thank you for the question. We have not checked this. We did not. We didn't focus on the comparison between the different anticholinergic agents. This is a very good idea. We can look at it because a lot of people were on these drugs. However, you know, this is a very large database, and there are still so much digging to do. Yes. We have.
My comment is in this work, because you get a good result. It's the high levels of IL-6, I think, in patients with sleep disorder. So we have the same results with higher levels of IL-6 in patients with dementia, and but without be treated with donepezil. So it's very interesting that we have the same results in excited levels in patients with dementia.
Mm-hmm.
And then, excuse me, may I ask a clarification? You said you get high IL-6 levels in patients that they use donepezil, or they do not?
Do not. With dementia, without donepezil, and then when they get the donepezil, the IL-6 levels lower. So
drop.
It will be very interesting. This.
Very interesting.
Mm-hmm.
Very. Thank you.
Yeah. Thank you. We can check it.
Very good presentation. Thank you, Maria. You. Thank you very much.
Thank you.
Other questions, comments? Is Nikos with us? I don't see. Is Nikos Karmeas with us today or no?
No, I don't see Nikos. I have a question about, so you talked about sleep as a predictor of MCI or dementia onset, and we've talked a bit about the variables that go into that. But what about sleep as an indicator of faster paced transition from MCI to dementia, or even accelerated progression of dementia? That's from the clinical pragmatics point of view. Can a case be made that detecting and managing sleep impairment early in dementia could be impactful to the course that the patient will follow?
Thank you again for this good, very interesting comment. I do believe that sleep, if you intervene on sleep, you may improve the progression. But as you can understand, the progression of dementia, I mean, the progression of cognitive impairment. So this is, in order, however, to check this hypothesis that I do believe we'll find, we need to have longitudinal data. So hopefully, the study we're now trying to conduct, to follow-up study, will give us the opportunity to check and find these associations. So I do believe that better sleep will lead to will be associated to better or less accelerating disease.
But so what a thought I have is there are 3 or 4 very large data sets that you could ask this question in. So for example, there's the ADNI data set, which has pretty good sleep data. There's the National Alzheimer's Coordinating Center, NAC data set. These are all easy to access, and these would be fairly straightforward. And you could have an initial, they don't have PSG, they have a limited actigraphy, so it's largely subjective. However, I think these are what I call low-hanging fruit, in that these are very large data sets that are publicly accessible. And I don't know that anybody has looked in either of those data sets about how subjective ratings of sleep early impact on course. And they are longitudinal, so food for thought. I would encourage a lot of opportunities exist in analyzing these data sets. And they've got their flaws, but they have a lot of advantages rather than waiting for your own data to show up, which will take some time.
If I may add something to your comment, Kostas, to your very useful comment, we presented recently through, it was in a virtual meeting, just a week ago, to the national meeting of American Academy of Sleep Medicine, some very interesting data from this cohort that Maria is talking about, where when we combine, the subjective sleep complaint with objective measures, just subjective is not enough. You might have seen in all of our literature, a subjective complaint combined with an objective measurement of sleep. And we're finding there that in MCI, at early stages, particularly the amnestic type, is associated really with high cortisol. And we can all agree, that high cortisol is not something good, for the system, is not something good for all the anatomic areas, hippocampus and so forth. So I think, although these are cross-sectional data, but they give us some idea that by addressing a specific phenotype, the one that combines both the subjective complaint as well as objective poor sleep, it might be, a group that if we intervene early, we may slow down the progression. And back to the trazodone, because trazodone lowers cortisol, this group, not the one that's advanced, but the early stages, the use of trazodone or some other medication that will have the same impact on the HIAA axis, I think is a promising tool.
It's an excellent suggestion, Ron. Thank you.
Other questions, comments? Well, it's about 5 after 6. Or for you, Kostas, is 5 after 11, correct? I would like to thank everyone for your attention, for your excellent suggestions and comments. And of course, thank Maria Basta for a very nice and interesting presentation. Of course, I'm biased, but it looks like it caught your interest also. Thanks a lot. Of course, I don't know if you want to close the session.
I want to thank Maria and you, Aleko, for putting this together. We saw some numbers from these seminars. Takis Vlamos presented them the other day. In particular, the YouTube version of these seminars are very popular. Some of the numbers we heard is the typical seminar gets about 100 people viewing them. So hopefully we're starting to reach the audience that we're looking for, and also accomplishing the goal of getting people to know what everybody's doing in Greece and starting to work together. So I'd like to thank you for contributing to the success. Good work.
Thank you very much, too. Bye.
Right now.
Thank you, Maria. Bye.
Bye.
Thank you, Maria.